Thank you very much for the introduction. I'm delighted and honoured to be speaking tonight. I've been asked to speak to you about two things. One is about altitude illness, and then I'm rather cheekily going to take some of the lessons that we have learnt from that to try and talk about the wider implications for trauma, critical care, COVID, cancer, and survival in general. So that's going to be a very whistle-stop tour in 40 minutes. I've done a lot of things, but actually I'm just a simple GP with a bit of curiosity. I like to think of oxygen as the good, the bad, and the ugly, which is a concept I've stolen from Mervyn Singer, who taught me intensive care at UCL. My background is pre-hospital care in the military, where I helped develop some of the techniques that we use today. And I was lucky enough to deploy to some very interesting places where all of the equipment we had to carry in ourselves. I have to be the climbing leader of the Caudwell Extreme Everest expedition back in 2007, which reflects really a lifelong interest in physiology. Many of you will recognize this quote, and this is Mallory, who was asked in the 20s, why would anyone want to climb Everest? And his rather flippant answer was, because it's there. This is what I think is the good about oxygen and why we think it's good. And I'm going to illustrate that by talking about altitude illness. So the basic problem with going to high altitude is that there's less oxygen available. Yes, the temperature decreases, there's less humidity, you're more exposed to solar radiation, but the bit that really affects the human body is how much oxygen is available to you. The barometric pressure decreases with increasing altitude. It's obviously worse in winter, and that Everest is uniquely placed. So some humans are just about able to climb it without supplemental oxygen if the conditions are right. You'll note from this slide that humans aren't designed to be on Everest, and the highest human habitation is at around 5,000 meters. This is a picture of our team going through the icefall on Everest. As you ascend to altitude, there are various changes that happen which serve to increase your oxygen delivery. We don't really understand this very well. We know that it varies massively between individuals. And I just wanted to say at this stage that it is not the same as sudden altitude exposure. So even if you've climbed Everest, if your aircraft was to decompress flying home, it probably wouldn't be much help to you. For acute mountain sickness then, it's fairly common with rapid ascent above 2,500 meters. The cardinal symptom is headache. It's accompanied by the other symptoms you can see there. And the really interesting thing for me is that it occurs 6 to 12 hours after arrival. And I just ask you to think about that. Why does it happen so long after you arrive? And we'll come back to that later on. The signs are very non-specific. You have increased heart rates, increased respiratory rate, but actually these are normal adjustments to altitude as well, so it's very hard to pick this out. This is our team reaching the top of the icefall with a lovely parhelion around the sun from the ice crystals. For me, the differential diagnosis of anyone in the mountains is that you must exclude the 3 H's of hypoxia, hypothermia, and hypoglycemia. And please remember that all of these can coexist at the same time. You can see the other differentials on the slide. We don't really know what happens with acute mountain sickness. We know that your ascent profile is really important, and we know that there are no sea level predictive factors. Essentially, if you want to know if you're going to perform well at altitude, you need to have been to altitude beforehand. And even then, it's not completely reliable that that will get you through the insult of ascending to altitude and voluntarily putting yourself in a hypoxic environment. So the best way to stop yourself getting altitude sickness is to adopt what we call a climb high and sleep low strategy, where you try not to ascend more than 300 meters above your previous sleeping altitude and have a rest day every 1,000 meters or 3 days, and adjust that to the group. There are many situations where that isn't possible because of the terrain of the mountain, but that seems to be the best strategy overall. This is our team moving away from Camp 1, which you can see in the bottom left of the slide, through the Western Combe, and just receiving a bit of a dusting off the slopes of Everest. The other way you can try and stop acute mountain sickness is to take Diamox. Essentially what this does is it increases your respiratory drive, particularly when you're sleeping, to increase your oxygenation. If you look at the top slide, this is somebody on a placebo at base camp. You can see from their respiratory pattern that they take a few breaths, then they stop breathing, they wait for their carbon dioxide to build up, then they take a few more steps. Underneath that is the oxygen saturation trace, which reflects that when they breathe, the oxygen saturation goes up a little and it decreases when they stop. This is effectively Cheyne-Stokes respiration. You can see the oxygen saturation is between 60 to 70%. Moving to the lower graphic, you can see that when you take acetazolamide, looking at the blue trace of the respiratory pattern, you have a nice steady respiratory rate, and you have steady oxygen saturation approaching 90%. High altitude cerebral edema is the opposite end of the spectrum of acute mountain sickness. Fortunately, it's quite rare and doesn't affect that many people. It seems to be selective to particular parts of the brain, such as the corpus callosum. The symptoms are those of any cerebral irritation. The cardinal sign is ataxia, so the inability to put one foot in front of the other. The best way to think of this is like asking somebody who's drunk to heel-toe walk. You can develop pretty much any neurology you like, and as it progresses, it can be fatal. This is our team of Sherpas who carried all our equipment on Everest, approaching advanced base camp at around 6,400 meters. The pathophysiology of high altitude cerebral edema is not really well known. We know that it results in increasing cerebral pressure. It probably has similarities with venous vascular flow and obstruction. The competing argument is what's called the tight fit hypothesis, i.e. that your brain, as it expands, as you develop some cerebral edema, it comes into contact with your skull. That increases the pressure, and it ends up in a cycle of increasing pressure. I think the reality is there's probably a bit of both, that it has both vascular and cellular components to it. High altitude pulmonary edema is a completely separate pathophysiology. Again, note the timescale. This happens 2 to 4 days after you arrive at altitude. It increases with rapid ascent. Recent research has suggested that most people who are trying to climb to the summit of Everest will almost certainly have a degree of high altitude pulmonary edema, albeit subclinical. The crucial thing here is that it occurs on reascent. When I first started going into the mountains, I used to be terrified of high altitude cerebral edema because you have someone who has gross cerebral irritation. You're very worried about them dying, but I now see it more as an extension of acute mountain sickness, which can be treated. High altitude pulmonary edema worries me much more because it tends to reoccur at the same altitude. So if somebody has had this at 7,000 meters, they'll descend, they'll feel absolutely fine. But if they reascend to the same altitude, there's a very good chance that they will get crushing pulmonary edema, which can result in them dying. It can be provoked by a viral illness, but if it's not, then that effectively indicates the ceiling that that individual is capable of acclimatizing to. It's a non-cardiogenic pulmonary edema. This is our team evacuating somebody with HAPE on Everest, and it really results from excessive pulmonary hypertension. If you go back to your basic lung physiology, you'll know that if you replace that, what your body is trying to do is to provide blood supply to areas of the lung that are well oxygenated. If you take the example of a pneumonia, then if part of the lung does not have any oxygen in it, you would divert blood flow away from there so that blood can be oxygenated. The problem at altitude, and with many illnesses, is that globally the lungs are hypoxic. When that happens, you get global pulmonary vasoconstriction. If you couple that with a leaky endothelium that develops at a high altitude, then you get fluid going into the alveoli. Excuse me. The symptoms are that it's usually preceded by acute mountain sickness. As you'd expect, you are very short of breath. You struggle to do any sort of exercise. Some may say that's completely normal at altitude. The difference is between somebody with HAPE at altitude and others at altitude is that you have a very, very prolonged recovery. You also have a paroxysmal nocturnal dyspnea and a cough and a very subtle hemoptysis. And unless you've seen hemoptysis at altitude, you may not recognize it. Often you need somebody to spit into the snow or cough into a tissue to see some subtle pink flecks of blood rather than the frank hemoptysis that we might be used to from the emergency department. The signs, again, are very non-specific. Your heart rate's up, your respiratory rate's up. You may or may not have a fever, but at the altitudes where HAPE develops, you're probably not carrying a thermometer. You may have some basal crackles. Again, you probably haven't got a stethoscope at these altitudes, so it's simply a case of putting your ear against someone's chest. Importantly, somebody can be asymptomatic and it can come out of nowhere. The picture you're looking at is the South Col of Everest, and you can see the route up to the south summit. You can't see the true summit from here. This is the highest lab we set up and was the highest lab in the world, and we managed to do some cardiopulmonary exercise testing at this altitude. I think I've said a lot of this already, that you have a hypoxic ventilatory response, exaggerated vasoconstriction, which results in pulmonary edema. What you're seeing in the picture is our team moving from the south summit to the summit, and the drop you can see in the middle of the picture is the Hillary step seen from above. This is the same individual you saw earlier who had some high altitude pulmonary edema, and you can see that it's resolved simply with descent. This is looking at the summit of Everest from the south summit. You can see going up the trail. I would just urge you to consider this picture with ones we see more recently, with 200 or 300 people queuing to get to the summit. They're very dependent on oxygen. The oxygen's running out. It's amazing how many people at 8,000 plus meters have, really don't know how to climb. If I zoom in for you, this is the Hillary step. It's now distorted since the earthquake, but it just gives you an idea of the scale. Were you to trip, it's probably a mile down either side, which is way beyond orthopedic height for those of you that remember reading The House of God. The summit itself is quite small. The Sherpas are Buddhists and follow a tradition of putting prayer flags there for blessings. I totally subscribe to their philosophy, but it is a terrible trip hazard. And this is the view of the top of the world reflected in someone's goggles from the summit. So I've told you the traditional teaching of what happens with altitude sickness. Is it true? Excuse me. You'll remember that I said altitude sickness occurs sometime after you arrive at altitude. This was known way back in 1969, that it took between 6 to 96 hours for somebody to develop the symptoms of altitude sickness. So my question is, if altitude causes altitude sickness, why does it take so long? And I'm going to try and tease you through my thoughts of that in the remainder of the presentation. This is all about oxygen for me. When I was a junior doctor, the first thing I was taught is that anyone who's critically ill must be given oxygen. There are numerous studies that show that what you need to provide to somebody is optimal oxygen. I'm not sure of the audience here, but I'm sure that we've got a mixture of pre-hospital paramedics and doctors and those working in the emergency department. And I would just ask you to think how many of you are aware that oxygen is a vasoconstrictor when given in high doses. When we set out to look at Extreme Everest, what we realized is that many of the changes we experienced as individuals going to extreme altitude were similar to particularly the respiratory observations we would make of patients in intensive care. Research in intensive care is terribly difficult. You would like to compare this person with this person, but they're all there for different reasons. Someone has cancer, someone is there for trauma, someone's got COVID, someone's been, had a heart attack. So comparing like with like is very difficult. We decided to just take one component, i.e. hypoxia. We deliberately exposed a number of volunteers to the hyperbaric hypoxia of ascending to Everest Base Camp and a few people to go higher to see what we could learn. This was done through the Centre for Altitude, Space and Extreme Environment Medicine at UCL. And we took a ton of gear up to Everest so that we could do detailed breath-by-breath analysis of what was happening to our bodies at altitude. Prior to going to Everest, one of the things that one of our researchers, Hugh Montgomery, had observed was something called Gene Polymorphism. The ACE gene has got nothing to do with how fabulous you are. It is to do with angiotensin converting enzyme, which most of us only know about through renovascular hypertension. Essentially, in the Caucasian population, 50% of people will have ID. I stands for insertion, D for deletion. 25% of people will be II, and 25% of people will be DD. When they did their study on climbers who had successfully ascended to high altitude, they found that if you're going to be good at altitude, you want to be II. And we'll return to that with COVID at the end of the presentation. They also saw that the reverse was true, that if you were going to die of ARDS, you were more likely to die if you were DD. So having the IE alleles of the ACE gene polymorphism made you perform well at altitude for that type of hypoxia, but it also made you more likely to survive the hypoxia of acute respiratory distress syndrome. If we look at oxygen and altitude, then this is the equation that anaesthetists learn for their exams, and then they sort of get rid of that bit. And essentially what it's saying is that it's looking at the oxygen content of your blood, which is a function of the oxygen saturation in the hemoglobin. If you work through the table here, you can see that at our base in London, the oxygen saturation was nearly 99%, and it decreased as we went through Namche Bazaar in Nepal, through to arrival at Everest Base Camp, where it was nearly just below 80%. And by the time we left Everest Base Camp, it had increased slightly as we had acclimatized. Our hemoglobin levels, as you would expect, increased in response to hypoxia. Following the equation then, the oxygen content of our blood decreased when we went to Namche, but by the time we arrived at Everest Base Camp, it was the same as it was in London. And certainly by the time we left Everest Base Camp, it was much higher. So the question is, if the amount of oxygen in your blood is the same, why do you become hypoxic at altitude, and why do you suffer from altitude illnesses? We've tried to unpick this. You'll understand the oxygen cascade, where oxygen flows from the air outside into your tissues. If you look at everything above the dotted line, the oxygen delivery at this stage is completely abnormal. And this is really important when we look at critical illnesses and how we measure how ill the people we're trying to look after are. And really, the main message of my talk is going to be that we need to do a lot more research on the role of the microcirculation and the mitochondria in both trauma and critical illnesses. And I'll try and highlight a few points in the last part of this talk. So this is me at around 7,200 meters. If you look at my oxygen saturation, my heart rate's 106, which is probably the same as it is trying to speak to you now. And my oxygen saturation is 56%. I'm unaware of any ill effects. I'm not doing very well at Scrabble. If I get a 4-letter word, I think I'm awesome, but I have no outward ill effects. Yet we measure oxygen saturation every day. And with COVID, as many of you will know, having an oxygen saturation of below 94 is one of the triggers for admission. But what does it really mean? This device that you can see Dan Martin using measures your microcirculation using a technique called side-stream dark field microscopy. When I first saw this, this was the William Harvey moment for me of our generation. This allows you to visualize individual red blood cells in real time. What you can see on the left is the capillary bed. Each of those black dots that you see is a red blood cell, and you can see them flowing at pace through the capillaries. If you look at the images taken from 6,500 meters, you can appreciate how sluggish the transit of the red blood cells is. So this stasis in the capillary bed is really important when we talk about hypoxia. There are other ways to try and measure what is happening with oxygen. These pictures are courtesy of Malcolm Russell, who many of you will know from Mars and Prometheus. This was a lady who had tried to hang herself. And what you're looking at here is just the regional tissue oxygen saturation measured by a device that's put over the thenar eminence of the palm, as you can see on the right-hand side. It's important to note that during this recording, all the other measures that we would use, such as blood pressure, oxygen saturation, etc., weren't showing anything because she was hypoxic for a long time. What you can see here with the red trace is that as the regional tissue oxygen saturation drops to a level around 50%, you lose cardiac output. CPR was started, he got return of circulation. It then dipped again, some epinephrine was administered. As we move to the middle of the picture, it dips again. A further dose of epinephrine was administered, and there was no response to it. By this time, the individual had been intubated, put onto ventilation, and moved into the helicopter for transfer. As there was no response to the epinephrine, the next thing that happened was that some gloved fingers were put into the thoracostomy holes, which is standard procedure for this air ambulance service. And you can see that the tissue saturation increased. Sorry, it was a needle thoracentesis at that stage. And then later on when it dipped, the fingers were put in. So that was in response to a probable pneumothorax as a result of the CPR. And again, I reiterate that pulse, blood pressure, and oxygen saturation was unreliable throughout this. There have been further studies with this, with London HEMS, but unfortunately it didn't reveal any clear benefit for trauma patients. So that brings me on to what I call the ugly, or the unknown unknowns with hypoxia. And I'll preface this by saying that I am still a GP. I dabble in science. I firmly subscribe to the concept that the more I look at things, the less I understand what's really going on. This is a survival curve from patients in ITU. What the white line shows you is how many people survive with time if you do nothing. Literally do nothing. The blue line shows the survival rate for people in which we, as doctors, apply our best interventions. And what it clearly shows you is that we don't know what we're doing. And I think a lot of this is because we are trained at medical school to subscribe to a notion of what is normal, and we spend a lot of time and effort trying to correct people who are ill to normality, whereas we don't pay attention to some of the things that their body is doing is a response that's been honed over millennia to the insult that's happened. This is moving on from the device I showed you that with the hanging, and it's looking at battlefield injuries in a American combat hospital. If you look at this, and this is a lifelong problem I've had with ATLS, with its concepts of degrees of shock and how you can measure shock by somebody being diaphoretic or their urine output or indeed their blood pressure. If you look at this person, you can see that their blood pressure is essentially stable throughout. If you look at their heart rate, you can see that it decreases as they're admitted to ITU. It then follows a bit of a zigzag, and it increases significantly, and it only goes down at the far right of the curve of the graph once the abdomen is opened and the bleeding has been stopped. And we know this from pediatrics, and we've relearned it in adult medicine, that actually the heart rate compensates and then it decompensates. And if you look at the blue line, which is the regional tissue saturation, you can see that it's almost a mirror of what's happening with heart rate. So it's far more reliable than blood pressure. This was a different study looking at people who were undergoing ECMO, and it was trying to predict who would survive and who wouldn't. It's using the same technology that I showed you that we used on Everest. The quality of the images is improved. The image you're looking at now is somebody who is a survivor, and you can see a very healthy passage of red blood cells through the microcirculation. If, by contrast, you look on the right at the non-survivor, it's an extremely sluggish microcirculation. So there is no way that there's going to be efficient oxygen transfer from the red blood cells to the cells. Returning to what we see on Everest, if you're interested to look at what I'm about to say in more detail, I refer you to this article in the New England Journal. But really what you see is that although the partial pressure in light blue decreases as we ascend in altitude, if you look at the content, so the amount of oxygen in our blood, it was preserved all the way up to 7,000 meters. And it was only at the highest levels where that decreased significantly. So going back to the point I made earlier, there's enough oxygen in your bloodstream, but it's just not getting to the tissues. In order for me to try and talk about that, I need to introduce you to mitochondria. This is a history of evolution of the planet in about 5 seconds. What you're looking at here is the level of oxygen in the atmosphere as far as we know since the beginning of this planet's history. For most of that time, it was at tiny, tiny levels. The 0.2 on the left is the 21% that we're used to now. And actually we had a time where we had hyperoxia, and that actually was an extinction event. The reason that we got oxygen was because a blue-green algae helped convert the carbon dioxide in the atmosphere into oxygen. And the second important thing that happened, what you're looking at in the on the right circle, is a mitochondria. A mitochondria is effectively very similar to a rickettsia, and somewhere in our evolution it was absorbed by a single cell animal, and that made the switch from anaerobic to aerobic respiration. But I would put it to you that the only reason we've developed into multicellular beings, and that the main reason we have a cardiorespiratory system, is to provide oxygen to the mitochondria, who in return are more efficient in giving us energy through the Krebs cycle than the anaerobic respiration that would happen before. If you want to know more about that, this is probably my favorite book about mitochondria by one of our collaborators, Nick Lane. So in order to look at mitochondrial function, we did something on Everest that hadn't been done before. We took biopsies to look at mitochondria whilst we were still at Everest Base Camp. Previous studies had all been done after the researchers had returned to sea level and didn't show any difference in mitochondria. We showed that mitochondrial proteins and regulators were changed, and I don't have time to go into the details here, but there was a massive upregulation in mitochondrial function, which was actually accompanied by a decrease in mitochondrial number. We did some quite elegant work looking at our cardiac mass, and it decreased by about 12% whilst we were on Everest, recovering over the next 6 months. We believe that was due to a shrinkage to try and make sure that any cells that were in the heart were close enough to a capillary to be fully oxygenated. I'm a firm believer that biology is not wasteful. This is a snake, albeit not a venomous one. Snake venom is one of the most complex biological substances that we've encountered. It takes weeks for an adult snake to make venom, and an adult snake can direct its venom dose based on the size of its prey, and it's also why most adult bites from venomous snakes are dry, because it realizes that you're not worth eating, you're simply a threat that it wants to scare away. But just bear in mind, it takes weeks to do that. I love this quote, which basically says that half the people that may have ever lived have been killed by an insect, who, as you know, are vectors of many diseases. And again, if you want to know more about insects, I would encourage you to look at this book. The reason I'm saying that is that, by contrast, the human body produces hypoxia-inducible factor, or HIF, every second. And what HIF does is it senses whether you're in a hypoxic environment, and if you're not, it immediately cleaves itself. So it's constantly doing this. If you think about how many days it takes to mount a response to an infectious disease, and COVID's a good example here, why is the body producing something constantly that it instantly destroys? That's a very, very complicated process, and it must be there for a reason. It was so important that actually the Nobel Prize recently was awarded for trying to understand how HIF works. From my perspective, what this has done is to say there are many, what we need to do is to try and find other ways to look at what's happening with mitochondria. This is one of the first projects looking at it. And the more that people look into HIF, you can see that it's involved with the retina, osteoporosis, atherosclerosis, osteoarthritis. It's involved with aging, cancer, cellular death. To the extent where there are people that think, could we all take a HIF pill to prevent diseases of old age? And are these all related to a chronic hypoxia? There are people who are looking at various ways of trying to ameliorate the effects of hypoxia. I don't think we've got there yet. I don't claim to understand what these studies really show. I just highlight them to say lots of people are looking at various ways to help us deal with hypoxia. Going back to HIF, as I said, there are people who are actively looking at targets for treatment in cancer. Returning to trauma, HIF-1 alpha is really important in looking at recovery from traumatic brain injury. We all know this, but if you look at the cause of death worldwide, trauma is, they've only got road diseases in here, probably a third of the way up, but we know it's really, really important. We know that alongside HIF, I talked about the ACE gene earlier, with how by saying that if you have the II allele of the ACE gene, that you're better at altitude and you're more likely to survive ARDS. It probably also offers some protection from malaria. And there have been studies done looking at ACE gene polymorphism and survival following major trauma. We are on the cusp of getting devices that will allow us to measure mitochondrial oxygen in real time. That is going to be huge. Understanding mitochondrial oxygen flux in real time will fundamentally change how we treat medicine, how we treat people who are critically ill. And the final part of my presentation is going to be about ACE gene polymorphism and COVID. So this study looked, what you're looking at here is on the vertical axis, you're looking at how many people are dying per day. And on the horizontal axis, you're looking at how many, what the percentage of people who have the II ACE gene polymorphism is. So if you go to the extreme right, you can see in Singapore, there's a high preponderance of II and a low mortality from COVID. And if you go to the extreme left, where you've got Italy, they have a lower preponderance of the II allele and a higher preponderance of, and a higher death rate. So we're all presented daily with statistics about COVID deaths that we're trying to unpick by looking at our healthcare systems and how we're treating them. But a lot of this may be predetermined by their ACE gene polymorphism. And although studies are being done to look at this from a research perspective, we've not yet reached the stage where we could use it clinically. This is sort of further studies looking at ACE gene polymorphism in COVID. And you can see that, again, if you've got the DD allele, it's not a good thing to have if you want COVID. So if you're good at climbing mountains, you've probably got a good chance of, good at climbing high mountains, you've probably got a very good chance of surviving COVID-related lung disease. This is the last one I'm going to look at. It said the point I said earlier that potentially looking at ACE genes may give us a clue to some therapeutic targets for COVID. These two graphs look at the age of the population in various countries. And again, it's looking this time at the DD frequency. And just to remind you, if you're DD, you are more likely to die. And again, that is borne out by the mortality in this study. I'm going to finish there. I'd just like to end by showing you my favourite picture from the mountains. This is the summit shadow of Everest being cast hundreds of miles over to the horizon. And I'm going to leave you with Mallory's other quote, which is less well known, but far more eloquent about why should anyone want to climb high mountains.